Okay, fine. Let me start. So, till now we have seen about extraoral examinations. We have seen examinations of lip. Then, now coming to nose. Why it is necessary to check the size and shapes of nose or to analyze the nose, and what things we'll by see according to our authentic case history. Okay, so most concerned parts are size of nose, contour of nose, and nostrils. Anybody can tell why it is important? Anybody?
Some persons have mouth breathing problem because of that
Sorry, I cannot hear you.
anterior.
Okay, let it be. There is some problem in audio. So why to analyze or why to see nose? Why the nose is important in authentic cases? Okay, nose is the part from where we do breathe. The initial breathing is from nose. So by seeing the nose, the shape and contour of the nostrils and the nose, see the length. It is very important when you have a short nose. There is mostly you will be having a short upper lip. Okay, if you have a longer nose and a short upper lip like this, so you will have to more concerned about the appearance of nose after your orthodontic treatment. That means if the patient is having proclined upper incisors and you decide to extract the upper premolars and retract it. What will happen after retraction? This lip will fall backward and this nose will be a crooked nose, like uh, there will be a old age appearance in the face. Okay, so you will have to look after, or you will have to consider the nose size and shape, and you should compare it after treatment things. So coming to the nostrils, you will have to check both the nostrils, the size and symmetry of nostrils. Any congestion is there, if any deviation of in the contour of nostril, what it suggests, that means impaired inhalation or impaired breathing problem. Your breathing is impaired due to stenosis of the nostril. So we'll have to. So subsequently, if the patient is not able to breathe through nose properly, there will be a mouth breathing. So you will have to join the links. Next thing is nasolabial angle. What is a nasolabial angle? So it's the angle between the lower part of nose, the base of nose and the upper lip. This angle, a imaginary line which is joining, which is tangent to the tip of nose and to the upper lip. This angle is normally 110 degrees. If it decreases, if the angle is decreases, in which cases it will decrease? Anybody can tell? Okay, fine. So
Proclination.
imagine if this upper face or upper arch, it is proclined, the upper anteriors are proclined, what will happen? This angle will reduce. Fine. This line will be towards the tangent line to the nose. Okay, this angle will be reduced. What it suggests? Acute nasolabial angle. That means your upper lip is forwardly placed and your upper incisors are proclined. Fine. If in due to cases where the upper incisors are retroclined, this angle will fall back. That means there will be a increase obtuse angle. Okay, fine. So after treatment or throughout the treatment, you will have to maintain this normal nasolabial angle. You will not increase the nasolabial angle. You will not decrease the nasolabial angle. So you'll have to keep an eye on the nasolabial angle during your treatment and treatment planning. Right. Then examination of chin. Why chin is important? Same way as a nose. What things you will see in the chin? Position of chin, like in this photo, there is prominent proclined chin. Here, a receding chin or a retrognathic mandible and receding chin. This is normal. A line, imaginary line, subnasally to menton should be a straight line. It should be in at the equal place. In this case, where the chin is retrognathic or short chin is there, you can afford to retract the incisors. That means if you retract the incisors, this lower face will be pleasant or acceptable. In these cases, where the chin is prominent and you retract the incisors or retract the upper and lower edges, what will happen? A saucer-like face will be there, a concave face will be there, there will be more prominent chin. So you will have to connect all these things and decide your treatment planning. What is this? This is a question for you. If I'm sorry, I cannot hear you, but still, just see the picture. Note down in your books if you have it nearby. Please note down this thing. What is this, and what is it called as, and why it is important to see? Okay, I'll give a hint. Think of some balls. That means any sports or any balls used in sports you can compare with a cricket ball, a tennis ball, and a football. What is it called as? What appearance is it, and why it is significant? Fine. So same as the nasolabial angle, there is a mentolabial angle, which shows the uh, position, shows the mentolabial sulcus. It is a tangent line of lower lip and the chin in the deepest part of the mentolabial sulcus. If it is decreased, what it indicates? If this angle decreases, it indicates the forwardly placed chin or prominent chin. If it is increased, sure, in these cases, the mentolabial angle will be decreased. In these cases, because there is no deep mentolabial sulcus and the chin is receding, it will be more. Coming to the intraoral examinations. Intraoral examination will start with the soft tissues. First will be the tongue. What things you will see in the tongue? Form, size, and shape. So everybody knows about microglossia, macroglossia, and so I'm not going to discuss about, but I'll be telling what points you should note in the case history. Okay. So first thing, the free movement of tongue. If your tongue is, the frenum is very thick and there is tongue tie, there will be no movement in the, no free movement in the tongue. And same ways, because of the there is no free movement of the tongue, there will be a collapsed arch. That means there will be disturbances in the arch form. Okay, if patient is having macroglossia, that means large tongue, so you will see markings of teeth, indentation of the teeth on the lateral borders of the tongue. Okay, arch will be wide because the arch has to accommodate the tongue. That's why the arch will be wider in macroglossia. In microglossia, there is no pressure of the tongue from the inside. So there will be a collapsed arch or a narrow arch. Keep it, note this down. Microglossia, a wider arch. Microglossia, a narrower arch, and macroglossia is wider arch. Here again forms a question, why this happens, why tongue is important for the maintenance of or appearance of the arch form. Note it down. These all questions I'm going to ask you when you join the college, and most probably within 2 months you will be here in the college. So please note down the questions. These are all your Viva questions. So why it is important, the macroglossia and microglossia. Why your tongue is important to maintain the arch form. There is a hint. Search about buccinator mechanism. Buccinator mechanism. Okay, fine. So the resting position of tongue. What is the normal resting position of tongue, and why we need to think about the resting position of tongue? Your answer lies in the previous question. So please search about that. What is why tongue is important and what is buccinator mechanism. So resting position, if your tongue is interposing between the upper and lower lip. There are some slides which will explain all this. So we'll carry forward this. Then examination of palate and examination of gingiva. In palate, depth, swelling, ulcerations, and cleft. These things we are going to check. Why any swelling? Because if you are thinking about giving any removable appliance, your palate should be your, your palate should be uniform. There should not be elevations or swellings. First, you will treat it and then deliver your removable appliance. Any ulcerations, clefts, and depth. So if depth is more, that means your arch is narrow and there are some chances to expand the arch. Okay, where the palate depth is shallow, that means shallow arch is there. That means your arch is more already a wider arch. There are no chances to expand it. So you will have to think other ways of space gaining for the treatment. Okay. So examination of gingiva, color and contour. Everybody knows it. You have seen this in a video. So I'm not going to focus more on this. Now coming to the frenal attachment. This is more important part of the authentic case history. Frenal attachment. Everybody knows types of frenal attachment: mucosal, gingival, papillary, and papillary penetrating. Okay, fine. So if mucosal frenal attachment is there, fine. If gingival is there, it's fine. If papillary attachment is there and the thick fibers will be penetrating in the papilla, this too will make problem, and this too will be more complicated to treat and to retain the malocclusion. For example, see here, papillary penetrating. Okay, the frenum is attached to the papilla here also. While your normal function, when you're talking, when you're drinking water, when you're eating something, there will be movement of your frenum. Okay, so if your frenum is attached to the papilla, which is between the upper two incisors, so this will create a midline diastema. Okay, there will be space. What is midline diastema? There is a space between upper two incisors, upper central incisors. Okay, if this is the problem, you will have to disconnect this attachment. Okay, if you treat this type of cases only just applying pressure and closing the space, it will not closed. Once you remove the appliance, it will appear again. Fine. Why? Because this pressure will be always there. So you will have to disconnect this pressure. You will have to cut this pressure. So there should be a frenectomy. Okay. It should be prior to treatment or after the treatment. What? So there are two thoughts of school. One says it should be prior to the treatment, prior to space closure. One says it should be after the space closure. So if you do frenectomy prior closing the midline diastema, so there will be a scar formation. You will surgically remove that frenum. renal attachment. So there will be a scar formation. Scar is what? There is thick fibrous tissues. So this thick fibrous tissue will not let you to space close the space. There will be a thick fibers or thick tissue will be. It will take more time. So it is always better to go for splenectomy after the treatment of midline diastema. This will aid in retention. Because of these thick fibers, this tooth will not move apart. So there is advantage of doing it later than the before the treatment. Now, adenoids and tonsils. You will say why we should look towards the adenoids and tonsils in orthodontic treatments. What's the relation? So if the patient time करायचं का? ऐकायला नाही येते पण मला काहीच मला काहीच ऐकायला नाही येत. So why we need to see the adenoids and tonsils? If the patient is having adenoids or tonsils, the swollen adenoids or tonsils, so these types of patient will be having breathing problems. So there, as I said earlier, you will have to connect the links. There is a chain. You will have to connect the links. Same thing here is if the patient is adenoid, has swollen adenoids and tonsils, so there will be a mouth breathing. What it will cause? So if the patient is having adenoidphasia or the tonsils, patient will be breathing from the uh, mouth. So subsequently, patient's face will be somewhat like this. There will be a long face. Nostrils will be pinched, a short. Okay, there will be an open mouth. Palate will be deeper because it is breathing from the mouth. So the function of this perioral muscles will affect the palate and it will be a narrow. There will be a proclination of the teeth, narrow arch. Obviously, teeth has to accommodate themselves. So there will be crowding or the proclination of the tooth. Okay. So these things you will have to notice. If patient is having adenoids or tonsils, will prefer go for adenectomy or tonsillectomy, and then will start your treatment accordingly. Then coming to the heart tissues. Heart tissue, first thing we'll see the dentition. Okay, so we'll start with the classification, or first thing we'll note by seeing the molars, the classification of malocclusion. Everybody knows when mesiobuccal cusp of first molar, it occludes in the mesiobuccal groove of lower first molar. It is an class 1 molar relation. When the distobuccal cusp is occluded in the mesiobuccal groove of the lower first molar. It is a class 2. See here, a distobuccal cusp is occluding in the mesiobuccal groove, and the mesiobuccal cusp is occluded between the first molar and the second premolar. Fine. A class 3 molar relation is what? When your upper first molar's mesiobuccal cusp is distally away from the mesiobuccal groove. It could be engaged in the distobuccal groove of first lower molar, or it should be resting between the first and second molar. Okay, the proximal fossas of first and second molar. In between the first mesiobuccal cusp will occlude in between the first and second molar. This is class 3. Okay, class 1, class 2, class 3. What is class 1? Upper mesiobuccal cusp is occluding in lower mesiobuccal groove. Class 2, upper distobuccal cusp is occluding in the lower mesiobuccal groove. Class 3, upper mesiobuccal cusp is occluding away, distally away from the mesiobuccal group. Fine. If patient is not having molars, any one of molar, any side of molar, so you will go to premolars. You will decide the molar relation or the class of malocclusion by the premolars. So what is class 1 premolar? These are very important things according to your theoretical part, theory exam, and the viva also. So what is premolar classification? See here, the mesiobuccal slope of upper first premolar, it is occluding with the distobuccal, see this, distal slope of lower molar. This is class 1. Okay. Then full plus class 2 is when your distobuccal slope of upper molar is occluding with the mesiobuccal slope of the mesial slope of the lower premolar. Class 3 is where your mesiobuccal slope is distally away from the lower distal slope of premolar. Fine. What is class 1? Just see the slopes. Okay, mesial and distal. Upper mesial slope will occlude in lower distal slope. Occlude with lower distal slope. This is class 1. Upper distal slope occludes with lower mesial. That is class 2. Upper mesial is distally away from the distal slope of lower. It is class 3. Now, if the patient is not having premolar also, or there is anatomical problems in premolar, so you are not able to decide the uh, class of the malocclusion, then we'll see the incisors also. Okay, what is class 1, class 2, and class 3 according to the incisor relation? Everybody knows normal overjet and overbite. Class 1 is normal jet. Class 2 is when there is increased jet. Okay, everybody knows increased jet. I'm sorry, I'm not audible, so I consider everybody knows the what is jet and what is overbite. Okay, jet is horizontal overlapping. If there is more space, the horizontal space between upper and lower incisor, it is class 2. And what is class 3? When upper and lower incisors are in inverse position. Okay, the crossbite, anterior crossbite is class 1, class 2, class 3. Class 1, normal jet and bite. Class 2, increased jet. And class 3 is reverse jet. Fine. So we have seen molar relations, premolar relations, incisor relation. If suppose patient is not having uh, molars, premolars, and incisors also, then what you will do? How will decide the molar? How you will decide the class of mal occlusion? Any guess? This is note down this question. Any other way from which we can, any other teeth which we can consider for uh, deciding the class or any other classification, you know. We'll have to find out the classification. Okay, note down it. Now, after the deciding the classification, we'll go for looking to overjet and overbite. As I have said right now, overjet is horizontal overlap, and overbite is vertical overlap. The normally upper incisors are 1 to 2 mm forward from the lower incisor. There is normal 2 mm of overjet. If it is increased, that means your upper component or upper arch is forwardly placed, or your lower arch is backwardly placed, or upper incisors are proclined, or lower incisors are retroclined. So you will have to note down the jet. You will have to measure the jet in millimeters. You will have to take the scale and measure the jet. You will have to note down, because if patient is having 12 of JET, there will be a different treatment planning. If patient is having 5 of JET, there will be a different treatment planning. Likewise, for overbite, you will have to measure the bite. Okay, how much part of lower incisors is covered by the upper incisors? If this tip of lower incisor is impinging in the upper palate, okay, palatal area, it is complete deep bite, 100% deep bite. If only incisor one third is covered by the upper incisors, if the upper incisors are covering till the middle third, like that, you will have to assess the overbite and overjet. You will have to note down it. Then what else you will see in hard tissues? Any missing teeth, uh, hygiene, hygiene practice, crowding. Uh, I'm sorry, I think so, there is some problem. Can anybody please message me? I'm still there. Just message if you can see this slide. And okay, fine, fine. So in hard tissue, intraoral examination, you will see hygiene practice, you will see any missing tooth or early exfoliation, history of early exfoliation, any trauma, once outdoor plays or any sports activity. You will see the crowding, you will measure the crowding, you will see spacings, if caries are there, if there is individual tooth position or shape anomalies are there. Okay, everything you will note down. Then after completing the intraoral examination of hard tissue, we'll come to the most important part of this case history is functional examination. What is functional examination? Those structures which are involved in functions, will check that. Any problem or any abnormalities within that area, you will check it. So one by one, we'll see. First will be postural rest position. Obviously, it should be postural rest position of mandible, intraocclusal clearance, path of closure of mandible, respiration, examination of TMJ, swallowing, and speech. These all things we'll see in functional examination. So, functional rest position. Normally, the functional rest position, the intraocclusal clearance in functional rest position is 3 mm between the canine region. So how will it determine the functional rest position? Patients should be seated erect on the chair, dental chair. Their patient should not be, the back rest should be proper. Patient should not lean backward, should be erect, and in these position and relaxed musculature. There are some techniques I'll explain further. So, uh, what is the rest position? Rest position where when your mandibular, all the muscles of your mandible, when closing the closing muscles and elevating muscles are in rest position. They are in contracted position and closed mandible is there. It is in rest position. So how do you record the rest position? There are something called as phonetic command and non-command methods. There are some methods to make the patient relax and record the interocclusal clearance at the rest position of mandible. How do you confirm that patient is in rest position? So there are some methods: phonetic, command, and non-command. What is phonetic method? You will tell patient to pronounce some alphabets or some words like starting from M or starting from C. Okay, or you will ask patient to talk like table in slowly, or Mississippi. This word Mississippi, you will have you will ask patient to repeat it: Mississippi, Mississippi. Okay, so when this pronunciation or this phonetics will make the muscles relax and patients will be in rest position. Or there is a non-phonetic method. The non-phonetic is you will observe the patient while talking. Okay, so observe the patient while talking, talk to the patient, and the point at that point when you feel that okay, the patient is in rest position, the muscles are relaxed, so you will ask the patient to stop in that position. Another thing is command method. You will ask patient to make yourself relax and close your mandible. Okay, so what are the methods? Phonetic, command, and non-command. In phonetic, Mississippi, letter starting, word starting from M or C. Then registration of the rest position, the occlusal rest position or the interocclusal clearance. There are three methods. Generally, there will be 2 to 3 occlusal clearance at the canine and premolar region. So there are three methods: direct intraoral, direct extraoral, indirect extraoral. Okay. So what is direct intraoral? After the patient is in relaxed position, the mandible is in rest position, you will take a vernier caliper, or you will take a divider, and directly intraoral, you will check the interocclusal clearance in the area of molar and premolar. So uh, if this is a direct intraoral method, what is direct extraoral method? Okay, so direct extraoral method is you will mark a point on the tip of nose and a point on the mandible, a chin of on the chin. So you will measure this the distance between these two points. Then after making the patients to pronounce some phonetics and all, after again you will measure this. So the sum of this, the difference of these two will be your interocclusal clearance. Fine. Then indirect extraoral method. Indirect extraoral method, you will measure the interocclusal clearance from a lateral cephalogram. Fine. Why this is important? Why your interocclusal space you should why it should be important to measure the interocclusal clearance. See, when you are giving some myofunctional appliances, what are myofunctional appliances? They will manipulate your forces from the extraoral musculature, and they will use it for the correction of malocclusion. So, or with these appliances, you will record the bite first. That means you will record the interocclusal clearance. Why? Because if the thickness, the intraoral, interocclusal thickness of your appliance is less than your uh, interocclusal clearance. For example, if patient is having interocclusal clearance of 4 mm and you are making bites of 2 mm, there will be no use, because when the patient is in rest position, your bite will be not in contact with the upper arch. They will be passive. Okay, so your appliance, the bite of appliance should be 2 to 3 mm more than your interocclusal clearance. For example, if the patient is having 4 mm of interocclusal clearance, your appliance bite should be 5 to 6 mm. Fine. Then path of closure. So have you studied this in Frosto? path of closure. There are, I'm sorry, the time is very less, so this will be the last slide. So there are three types of path of closure: forward path of closure, backward path of closure, and lateral deviation. Everybody knows when we open the mouth, so your condyle will slide anterior to the from in the glenoid fossa. When you close it, it will be again in the post. Your condyle will be at the posterior aspect of the glenoid fossa. So, what are these forward, backward, and lateral deviation? When you are having edge-to-edge contact, or the patient is having class 3, skeletal class 3 malocclusion, there will be a forward path of closure. So, patient will forward the mandible